Hello, I'm Laura Rooney. As a nurse practitioner, I see and treat pain complaints on a daily basis. We are all familiar with the characteristic appearance of the patient suffering from acute pain: grimacing, guarding, elevated heart rate, blood pressure, and perhaps even mild diaphoresis when the illness or injury is severe. However, chronic pain generally presents differently. These patients often do not exhibit the classic pain behaviors which may lead you to characterize them as drug-seeking or malingering, but the pain these patients suffer from is real and relentless. The pain and impact follows them day after day, and over time the body adapts, which explains the absence of typical physiologic responses you might expect from someone reporting pain on a scale of 7 out of 10. But make no mistake, the absence of visible signs of pain only complicates the diagnostic process. As a provider, if your patient reports pain, then by definition, they have pain, whether they show it or not. Although the goal of care is always to identify and remove causes of pain, with chronic pain, you are often left treating the symptoms. Drugs such as opioid analgesics, muscle relaxers, non-steroidal anti-inflammatories, or anticonvulsant drugs that control the pain experienced from neuropathic pain can be very effective. It is almost impossible to effectively treat a chronic pain complaint without addressing the psychological and psychosocial aspects of it as well. Chronic pain takes its toll on interpersonal relationships. It may involve depression, anger, anxiety, and sleep disturbances, requiring a patient-centered approach that addresses the whole person. Although the commonly used OPQRST clinical tool works well for acute pain, it also has applications in the evaluation of the chronic complaint. It is important to pay attention to the changes in pain complaints over time. While change may be an evolution of the pain process, accepting this without a thorough assessment may cause you to miss new conditions. Let the acronym guide the questions you ask the patient, with a focus on changes that may have occurred since you last saw the patient. Onset: how long have you had the pain? Has it changed recently? Provoking: what makes your pain worse? What makes your pain better? Quality: what does it feel like? Is it sharp, achy, dull, or needles? Try to let the patient find their own words to describe it. Radiation: does the pain go anywhere? Can you point to where the pain is with one finger? Severity: what is your pain on a scale of 1 to 10, if 10 is the worst pain you can imagine? Timing: how often do you notice it? Constant? Intermittent? Daily? If the patient has been evaluated by other specialists, such as orthopedics, neurology, or pain management, keep this in mind. However, worsening pain may indicate it is time to repeat imaging or laboratory studies to look for changes. Treatment options for pain exist on a sliding scale, from least invasive and conservative to aggressive. Where you start depends on what has been done for the patient to date and the extent of the injury. Often patients with chronic pain will be treated in the primary care setting and referred to specialists for interventions when appropriate. For example, if you feel a patient would benefit from an epidural steroid injection for treatment of radiculopathy, then consider a referral to pain management. A successful procedure may mean fewer medications for your patient. If you cannot control pain with medications you prescribe, you should consider a referral to a pain management specialist. These practices generally offer patients comprehensive care with behavioral medicine, occupational therapy, and procedures when appropriate. As the primary care provider, you will still manage other chronic medical conditions, so open communication between you and the consulting practice is important. Designing a plan of care will identify common goals and set appropriate expectations. Finally, remember that when pain does not look like you expect, that does not mean it is not present and very real for the patient. The uncertainty of the process and the duration of this condition, along with fears of medication dependence, may cause a great deal of patient anxiety. Alleviate worry with open and direct communication. Develop the plan with your patient and pharmacist to create a patient-centered approach. I hope you find this information helpful. This is how I practice.